Hello, today we'll be studying about diuretics. So these are the terminologies in diuretics what you have to know. So what is a diuretic is something which will increase the excretion of water from the body. Along with water, sodium chloride and bicarbonate ions are also excreted. So the net result will be increase in the urinary outflow and urinary pH, and there will be some ionic composition of urine and blood will be altered. So these changes can be seen. There is also something called as natriuresis. Natriuresis mainly means those things which will increase the sodium excretion. Similarly, aquiuresis will increase the water excretion from the body. So, a short brief explanation about the anatomy and what is the physiology of renal system. So, renal, we know this is the kidney. So, this is the cortex, medulla, and from this, the urine which is formed is uh, secreted into the renal pelvis. From here into the ureter, the urine is flowing. So the unit of kidney is the nephron, which is in this picture. So each nephron contains various parts. That is, the first thing is the Bowman's capsule. This is the proximal convoluted tubule, descending loop. This is the loop of Henle, ascending loop, distal convoluted tubule, and the collecting ducts. So this is the parts of nephron. So what happens in this renal nephron is the blood which will enter into the Bowman's capsule through the afferent and leave the Bowman's capsule through the efferent will undergo some process here, and the result of which is the net 16 to 20% of the fluid that is the blood which enters is filtered in the Bowman's capsule as the Bowman's or the glomerular filtrate. Okay, once the filtrate enters here, so there will be various process or secretion and excretion which is happening in various part of the kidney. So to begin with the first part, that is the proximal convoluted tubule, few important ions and uh, substances are reabsorbed, and this will occur mainly by an active transport system using anionic and cationic reabsorption mechanism. Okay, there is cationic transporters and ionic transporters here. So the things which are reabsorbed are glucose, amino acid, calcium, and bicarbonate. Also, maximum amount of water, 60 to 70% of the water is reabsorbed here. And things which are secreted here are various antibiotics and substance and waste products, that is uric acid, creatinine, which is a metabolic waste of the body. Those are secreted here. And then in the descending loop, there will be absorption of water only. Loop of Henle, nothing is done. There is no secretion or excretion. And then coming to the thick ascending loop, there is an important active transport mechanism, that is sodium potassium 2 chloride ATPase. Okay, with this all these ions, that is sodium, chloride and potassium, are reabsorbed from the urine. And on the other side, there is an active potassium pump which will pump the excess potassium into the lumen. Okay, since the positivity in the lumen increases, in turn magnesium and calcium, which are bivalent ions, they are reabsorbed into the body. And then moving on to this distal convoluted tubule, here also there is an active symport system, that is sodium chloride. Okay, which will increase the reabsorption of sodium and chloride into the body. And also under the influence of parathyroid, calcium is also reabsorbed in the distal convoluted tubule into the body. So the next in the collecting duct, what happens is there is two hormones which will act here, that is aldosterone and ADH. With the help of aldosterone, sodium and chloride is reabsorbed. Okay, and then next with the influence of ADH, that is anti-diuretic hormone, as the name suggests, it will decrease the water excretion in the urine, so water is reabsorbed into the body. Why I explained you this is, if you understand this process, the mechanism of various diuretics will be easier to understand. Uh, with this, you can understand that renal have the following function. The first thing is that it is important in in balancing the electrolytes, plasma volume, and acid base. So all these are balanced by the kidney, and then it is one of the place where there is activation of vitamin D. Okay, and then kidney is involved in the synthesis of erythropoietin. Okay, and this is the this is involved in synthesis of RBC, WBC, and various elements. And then urokinase, which is an anticoagulant, it is also synthesized in the kidney. And as it is one of the excretory organ, so waste products like urea, creatinine, uric acid, and all these are excreted from the kidney. Coming to the classification of diuretics, so diuretics are classified as highly efficacious diuretics, moderate efficacious diuretics, and low efficacious diuretics based on their diuresis efficacy. So high efficacious diuretics are loop diuretics, which include furosemide, torsemide, and other drugs. Moderate efficacious are thiazide group of diuretics, which are hydrochlorothiazide, chlorthalidone, and all these. And then low efficacious diuretics involve potassium sparing diuretics. In that you have aldosterone antagonists and inhibitors of renal epithelium. Carbonic anhydrase inhibitors are acetazolamide. Osmotic diuretics involve mannitol, urea, and glycerol. Site of action of diuretics, we saw different classes. So where do they act? You will be seeing in the slides. So the first part, that is on the proximal convoluted tubule, you have group carbonic anhydrase group of inhibitors will act. What do? They will prevent the formation of carbonic anhydrase is the enzyme which is involved in the formation of bicarbonate ions. So those formation is inhibited. And then the next group, osmotic diuretics, it will act on all the part, but mainly on the descending loop. And the next class is loop diuretics. As the name suggests, they will act on the loop. What is the target? This is the target. Sodium potassium 2 chloride ATPase is the target. Distal convoluted tubule, thiazide group of diuretics. See, this thing you have to remember, thiazide and loop diuretics, they are secreted here, but their action is on the different part, that is on the DCT and loop. So thiazide will act on distal convoluted tubule, inhibiting the sodium chloride symport system. And potassium sparing diuretics will act in the collecting ducts. There are two classes here. One is which will inhibit the sodium, and the other one which will inhibit the aldosterone. So both will act at this level. So moving on to individual classes. So loop diuretics, as we have seen, furosemide, torsemide, bumetamide, and ethacrenic acid. Their site of action is loop of Henle, thick ascending loop of Henle, and they are called as high ceiling because with increasing dose, the diuretic efficacy can be up to 30 to 40%. That is, 30 to 40% of water which is present in the glomerular filtrate can be reabsorbed. This is not seen with any other class of drugs. That is why it is called as high ceiling diuretics. So mechanism to just brush up sodium potassium 2 chloride. This is where it will act. So all these are inhibited. In turn, the potassium which was pumped into the lumen, that is also blocked because of this. And then this magnesium and calcium reabsorption is also hampered. So there is disturbances in 5 different ions. This is very important. You have to remember sodium, potassium, chloride, magnesium, and calcium. So 5 different ions is disturbed here. So all these are excreted in turn. So coming to the uses where this loop diuretics are used, it's used in all the edematous condition like congestive cardiac failure, pulmonary edema, hepatic edema, which is seen in case of cirrhosis. Ascites is seen, And then in case of renal failure also, in the nephrotic syndrome, renal edema. So these conditions, it is the first choice of drugs to decrease edema, that is diuretics. So this is one of the important indication of diuretic class. And then the next other uses are, it is used in case of renal failure, severe hypertension in combination with other antihypertensives, and hypercalciuria, hypokalemia. This is because it is inhibiting 5 different ions, right? So calcium reabsorption is inhibited. So in case of acute hypercalcemia, which is seen in case of malignancy, you can use this drug because they will increase the calcium excretion. And also forced diuresis in case of few chemical toxicity like bromide, iodide and fluoride, because these monovalent ions are reabsorbed from the same channel where sodium is reabsorbed. Okay, we are blocking sodium channel, so reabsorption of this also in turn will be blocked. So next, coming to the side effects of diuretics. So hypokalemia. So all these you will understand because sodium, potassium chloride, magnesium and calcium. So these things we know now. So it will cause hypokalemia, hyponatremia. Okay, hypokalemia will lead to metabolic alkalosis. Hyponatremia can lead to dehydration and hypovolemia. Okay, hypomagnesemia and calcemia. This much we know. Okay, and then next important thing which you have to remember here is ototoxicity. Okay, and very much important. Okay, ototoxicity, and this is seen only with ethacrenic acid. That is why this drug is not used nowadays. Okay, others also may cause, but this ethacrenic acid will cause. That is why it is not used nowadays. And hypercalciuria, it is because of volume induced uric acid reabsorption. This can also happen. Hyperglycemia and lipidemia, because it will decrease the insulin secretion, leading to hyperglycemia and hyperlipidemia. Allergic reaction, because they are sulfur derivatives, so they can cause skin rashes. Few GI disturbances like nausea, vomiting and diarrhea, and weakness, fatigue, hypotension. These are other side effects with loop diuretics. So moving on to the next class, that is thiazides: hydrochlorothiazide, chlorthalidone, polythiazide, benzoflumethiazide. These are the thiazide drugs. Thiazide derivative, thiazide related agents are also there. That is chlorthalidone, clopamide, indapamide, metalazone and zipamide. So these are thiazide group of drugs. Mechanism of action we have already seen. It will act on, it is secreted from PCT, but it will act on DCT, that is distal convoluted tubule, inhibiting the sodium chloride symport system. Okay, sodium and chloride reabsorption is inhibited. And its indication, it is the first line drug in case of hypertension. Very important. It is the first class of hypertensives. Antihypertensives, thiazide is one of the first line choice of drugs. Among those, thiazide group of drugs should be indicated in case of hypertension. And then in case of congestive cardiac failure, the edema due to CCF can be reduced. Mild to moderate cases, it can be reduced by thiazide group of drugs. And other edemas, as we saw with loop diuretics, same thing: hepatic and renal, nephrotic syndrome, cirrhosis. In those cases, ascites and renal failure related edema, all those will be reduced with this diuretics. Nephrogenic diabetes insipidus, this is also very much important use of thiazide group of diuretics. Why? Because since these class of drugs, that is thiazide diuretics, reduce plasma volume, there will be a significant decrease in the glomerular filtrate. Paradoxically, it is not very much, but paradoxical decrease in urine output is seen. So it is good to use. If at all you have to use some diuretics in case of diabetic insipidus patients where there will be increase in urine, so thiazide diuretics can be indicated. And they will also prevent calcium excretion in case of osteoporosis and calcium nephrolithiasis in these conditions, because parathyroid related calcium reabsorption is also hampered by thiazide group of diuretics. So coming to the adverse effects of thiazide group, hypokalemia is also there with thiazide, but hence this should not be given in case of in patients who are taking digitalis, because they will increase the toxicity. Metabolic alkalosis, hyperuricemia, hypotension, natremia, magnesemia, and hypercalcemia. All these are also there, but not as significant as loop diuretics, but they are also few side effects. Hyperglycemia is also important ones, because they also inhibit the insulin secretion. Impotence is one of the side effects with thiazide diuretics. This is not there with others, so you have to remember impotence is seen with thiazide. Weakness, fatigue, anorexia, all these are mainly related to ion disturbances. GI disturbances and allergic reaction can also happen. So moving on to the next, that is low efficacious diuretics. We have potassium sparing diuretics. So they are weak diuretic action. Uh, on long-term use, they can prevent myocardial hypertrophy and myocardial fibrosis, which is remodulation procedure in case of CCF. So potassium sparing diuretics, they are mainly used in combination with others, because as the name suggests, potassium sparing, they will prevent hypokalemia, which is more or it is one of the significant side effects with all the other class of diuretics. So that is prevented in case if you use potassium sparing diuretics. So in this you have two classes. One is sodium channel inhibitor, the first class, that is sodium channel inhibitors, which will include amiloride, triamterene. Okay, these two drugs. And the next one is aldosterone competitive antagonist, that is spironolactone, eplerenone. Okay, we saw there is reabsorption of sodium through sodium channels. So this channel will be blocked by this sodium channel inhibitors. Okay, they will inhibit sodium reabsorption. In turn, potassium retention is also uh, potassium secretion is also inhibited, so potassium is retained in the body. Then next one is the aldosterone competitive antagonist. So aldosterone is it's a hormone, we saw there on the collecting ducts it was acting, and sodium chloride it was helping to reabsorb. In turn potassium was excreted, right? So if sodium chloride reabsorption is inhibited, potassium excretion will also inhibit. So that is the action of these two potassium sparing diuretics. It is same in the picture. Aldosterone will uh, cause reabsorption of sodium and chloride and excretion of potassium. So this is what is blocked, and thereby it will increase the, so see the potassium which was excreted, so this is also inhibited. And the other one which is acting on the sodium channel, so this is where it will act. Indications where they are used is they are also used in as an adjuvant to antihypertensive, because they will prevent hypokalemia. This is one of the important feature of this class of diuretics. And along with this, it is used in case of primary and secondary aldosteronism, because and for this condition which we use is mainly spironolactone and eplerenone, because they are aldosterone antagonist. Okay, only those two class. Liddle syndrome is and nephrogenic diabetes insipidus, it is also used in this condition. Coming to this adverse effects with potassium sparing, hyperkalemia can occur because they will prevent potassium excretion. Anti-androgenic effect is seen with aldosterone antagonist, that is spironolactone. So what are the effects? Gynecomastia, decreased libido, impotence in case of male, and menstrual disturbance in case of females. So these things can be seen in with aldosterone antagonist. Megaloblastic anemia is one of the side effects with triamterone because it will inhibit. It is a folate antagonist. So next class, that is carbonic anhydrase inhibitors. So acetazolamide, dorzolamide, these are the drugs. So this reaction is very important. See, carbonic anhydrase is an enzyme which will catalyze this reaction. That is, they will carbon dioxide and water, they will form H2CO3, carbonic ion. So this carbonic ion, it is unstable, it will be converted into bicarbonate and H plus. Okay, this reaction will happen in proximal convoluted tubule. So this is what is inhibited. So by this, bicarbonate ion formation is decreased by this carbonic anhydrase inhibitor. But see, potassium is indirectly dependent on this. It is an active support system, right? So all these will be hampered if bicarbonate ion is not formed. Where we use carbonic anhydrase inhibitors is, these are the uses. So this is very important. Glaucoma is, in case of glaucoma, uh, carbonic anhydrase is used as orally and also topically, both the ways, orally and topically. Topically used carbonic anhydrase inhibitors are dorzolamide and brinzolamide. They are topically used. So they are used in case of glaucoma, where they are also to decrease the intraocular pressure. We use these drugs. In case of acute mountain sickness, also it is used to inhibit the secretion of bicarbonate in case of choroid plexus, and which will lead to acidosis of CSF resulting in hyperventilation. So these things will be inhibited. So this is also one of the important indication, that is acute mountain sickness. What is the class of antidiuretics which is used? It is carbonic anhydrase inhibitors. And then in case of urinary alkalization, to prevent uric acid and crystalline cystine stones, also these things are used. As diuretics in case of edema, it is also indicated. One of the important use is in case of epilepsy. It is used as an adjuvant because they are known to increase the seizure threshold. Okay, so as an adjuvant, it is one of the newer indication. So coming to the side effects of carbonic anhydrase inhibitors, so these can cause metabolic acidosis because they increase the bicarbonate excretion. So acidosis can happen. Renal stones because phosphate and calcium are excreted. Uh, Hypokalemia can occur with this because uh, we have seen in the previous diagram, but that reabsorption of potassium is dependent on bicarbonate ion in proximal convoluted tubule. So it can cause hypokalemia. And these are contraindicated in case of liver cirrhosis because carbonic anhydrase inhibit the elimination of urea. Okay, urea. This can lead to hepatic encephalopathy. So that is why it is contraindicated in cirrhosis. Important. Liver cirrhosis, they are contraindicated. So coming to the last class of diuretics, that is osmotic diuretics, as the name suggests, they will increase the urine excretion, they will form osmosis. These substances, mannitol is the prototype, it is just an inert substance. Okay, so these are the properties of osmotic diuretics. They will move freely in the glomerular, they can easily pass through the glomerular capsule as a glomerular filtrate. Once they enter, they are not at all reabsorbed from the tubular. That is, there is no reabsorption of this substance. So they will just act as an inert substance. So and increase the solute concentration. So the water which is present in the body will enter into the lumen. Thereby they will increase the water content of the urine. That is how they will produce diuresis. They will increase the excretion of water and electrolytes, and they will increase the urine volume and rate of urinary flow. Where are these used? They are mainly used to sudden decrease in intracranial and intraocular pressure. So in case of glaucoma, okay, and brain edema, where there is raised intracranial tension, so there it is used. And also in few conditions where there is disequilibrium syndrome after hemodialysis, or in case of rhabdomyolysis, all these conditions to decrease the uh, blood volume, it is used. Um, Coming to the adverse effects, since the water from the intracellular compartment is removed, so initially there will be increase in the plasma volume. Potentially there can be dangerous heart failure and pulmonary edema. So this is one of the side effects of this class. It is not routinely used unless it's in case of emergency like raised ICT or IOP. Okay. Increase in water excretion can lead to hypovolemia and hyponatremia. This is also one of the side effects. Hypersensitivity reactions is also seen, and with urea there is vein thrombosis, pain if extravasated, and also glycerin can result in hyperglycemia and glycosuria. So these are side effects of osmotic diuretics. So coming to the newer agents. Vasopressin antagonist. Vasopressin is an antidiuretic hormone, right? So it is an antagonist of vasopressin. So it will do something which is opposite to ADH. So that is the work of this class of drugs, that is tolvaptan, conivaptan, and lixivaptan. So these are the drugs. They will act by inhibiting ADH. ADH will increase the water reabsorption. So which will inhibit ADH will increase the water excretion from the collecting ducts, and they will increase the free water diuresis. So this is indicated in inappropriate ADH secretion syndrome. So this is the summary of this class. So site and mechanism of action of all the class of antihypertensives is mentioned here. So it is just a quick reminder. Osmotic diuretics, it will act on all the parts, that is proximal loop and collecting, and they will inhibit sodium and water reabsorption. Carbonic anhydrase mainly proximal convoluted tubule, and they will inhibit the bicarbonate reabsorption. Loop diuretics on the loop of Henle mainly on thick ascending loop, so they will inhibit sodium potassium 2 chloride ATPase. Thiazide distal convoluted tubule, so they will inhibit sodium chloride and sodium chloride co-transporter in the distal convoluted tubule. And potassium sparing diuretics, they will act on late DCT and collecting duct part, and they will mainly inhibit the reabsorption of sodium. So this table will help you to quick glance with all the class with mechanism. If you know what ions, side effects will be easier. Thank you.